Muy buenas tardes a todos. Gracias por participar en la sesión inaugural de las reuniones académicas de NEAS. NEAS es la red de neurovirus emergentes en las Américas, que es un grupo multidisciplinario del cual el mayor enfoque está en estudiar las enfermedades virales e infecciosas emergentes en las Américas y la relación con la enfermedad neurológica. Hoy tenemos el gran honor de tener el conferencista de la reunión inaugural, el doctor Nath. Más tarde haré la introducción del doctor Nath, pero esta es nuestra primera sesión del año. Y el objetivo de esta sesión es integrar desde el punto de vista académico todos los colaboradores desde el área de virología, enfermedades infecciosas, neurología, epidemiología y todas las áreas que están enfocadas a entender los problemas neurológicos e infecciosos en las Américas. Hoy tenemos el gran honor de tener al doctor Nath. El doctor Nath es un neurólogo clínico, es el director clínico del Instituto Nacional de Salud del Instituto de Enfermedades Neurológicas. El doctor Nath ha sido en los últimos 30 años uno de los pioneros más importantes de la neurovirología en el mundo. Sus investigaciones en HIV-VIH han sido importantes para entender la patogénesis de los problemas neurológicos asociados a HIV. De tal manera que hoy damos la bienvenida al doctor Nath y le agradecemos su participación y su conferencia. Él nos va a ilustrar acerca de la patogénesis de los problemas neurológicos en el COVID-19. Y en esta manera queremos iniciar con esta conferencia inaugural todo el programa académico de las gran sesiones académicas de NEAS. Nuevamente, gracias a todos los participantes y damos la bienvenida al doctor Nath. Dr. Nath, thank you so much for joining the meeting of the NEAS group, and I will allow you to share your slides. But I greatly appreciate the fact that you are participating in our meetings.
Gracias, Carlos. I wish my Spanish was as good as yours, but poquito español here. But thank you very much for inviting me to present this talk. I'm really honored to have the opportunity to do so. And Carlos asked me to talk about the neurological manifestations of COVID. I'm sure a lot of you have probably seen these patients, and I would love to hear what your experience is. I'm going to share with you what we have seen so far, and where we think we're going with this illness. So let me just share my slides. Okay. So as Carlos said, I'm in at the National Institutes of Health. This is a suburb of Washington, D.C. So that's where the seat of the government is, and the National Institutes of Health is an important arm of the federal government, where we have an intramural program, and within this intramural program, there's a hospital, there's a whole research center here, and there are about 70 buildings on campus. So we do all kinds of clinical and bench research here. And so this in front of you here, these three buildings together are the clinical center, which is the hospital. And so it's an outpatient and inpatient unit. And my office and my research lab is located in this clinical center. And this is just to emphasize the public health importance of this pandemic. So global infections, nobody knows exactly what the right number is, but 500 million is probably an underestimate. WHO thinks that their numbers are 50 million people died, but again, these are all underestimates globally. In United States, yesterday, it was announced that 1 million people have died. These are official numbers. So unofficial numbers are probably much, much greater. At the peak of the pandemic, And within the United States, about 4,000 people were dying every day. And even now, there are 300 to 400 people dying every day in the United States. Okay. Although we are behaving as though the pandemic is over, the number of deaths are still very significant. And number of hospitalized children is also going up drastically. So this is the Washington Mall at the time when Joe Biden was inaugurated. And so you can see the Washington Monument there. And at this mall, there are all these flags. Each flag represented an individual who had died of COVID. So there were 400,000 flags planted at the time when Biden was inaugurated. A year and a half later, you can see that the number have doubled, actually, more than doubled. Right? So this pandemic is far from over. Right? Okay, so we also know that the COVID is caused by a coronavirus, and the coronavirus is SARS-CoV-2. But there are a number of other human coronaviruses that exist. So there are a total of 8 human coronaviruses, including SARS-CoV-1 and 2. And the interesting thing is that all of them cause neurological complications. I think that is the issue, is that a lot of these pandemic pathogens cause neurological problems, but it remains underappreciated. People don't realize the breadth and depth of the complications that can occur from coronaviruses, a lot of the other pathogens. People get focused on just the primary organ that is involved, and they don't quite realize the problems that occur within the central nervous system. So now if you look at SARS-CoV-2, there are further number of different variants. And so, as you may have heard, we first had the Alpha variant that came out of Wuhan, and then subsequently there have been other variants, and currently the predominant variant in the world is the Omicron. And amongst Omicron, there are other subtypes, and at least in the United States, currently it's BA2 is the dominant one. And in South Africa currently is BA3 and BA4, okay? And they just reported yesterday that there's 5 and 6 that they have just identified. The importance of these things is that the newer ones that emerge are more infectious than the previous ones, okay? So the viruses and RNA viruses keeps mutating every time it replicates, and the ones that survive is the survival of the fittest. So the one that's going to continue to replicate is the one that has the best ability to bind to its receptor. So the affinity for the receptor keeps going up and up and up, and it becomes more and more infectious. Previous isolates, pandemics of coronaviruses, they would affect humans, and then slowly they disappeared. And they dissipated because through the process of mutation, they became more infectious, but they had a huge deletion of about 200 base pairs, okay? And that base pair deletion make them less virulent, more infectious, but less virulent. When that happens, then the virus will disappear because it becomes like a vaccine itself, right? Unfortunately, with the SARS-CoV-2, it hasn't become less lethal. So it's still virulent and is getting more infectious. So I think that's what surprised everybody. People thought that, you have this alpha, it's just going to go through the population and acquire a mutation, will be gone. But unfortunately, the pathogenicity hasn't changed, but the infectivity keeps going up so far. Okay, so the question is, what are the neurological complications? And so you can divide them into 3 groups, okay? Acute, subacute, and chronic. And the acute are, loss of smell and taste. And then these patients are, fairly sick. They're hospitalized with severe respiratory infection. So it's not, unconceivable that they're going to get metabolic encephalopathies because you have end organ damage to the heart, lung, kidney, then it's going to affect the brain in some way. They do develop strokes. I'll talk a little bit more about it. Actual viral encephalitis is extremely rare. Only very few cases have ever been reported. And my guess is unless you're severely immune suppressed, it probably doesn't occur. There are some cases that we suspect of Ondine's curse. That means patients die suddenly. And I'm going to show you some of that pathology because we obtained some brains from patients who may have had that. At least they had sudden death. Then there are the subacute inflammatory syndromes. And so those can occur with almost any viral infection. You get acute disseminated encephalomyelitis, hemorrhagic encephalopathy, or limbic encephalitis. But there is this multi-system inflammatory syndrome that is quite unique to SARS-CoV-2, and it occurs predominantly in children. It can occur in adults also. Okay. But the biggest problem we're going to face for years and years to come is this long COVID. And I'll talk a fair bit about that. Okay, so the first thing I'm going to tell you is that vascular injury is key to the pathophysiology of SARS-CoV-2 in the acute and in the subacute phase. So there are multiple different types of strokes that can occur in this population. So you can get, here's an infarct, as you can see on a CT scan, on both sides of the brain, right? You get bilateral infarcts. That's very unusual to occur. And the other interesting thing about these patients is that not only do they have blood vessel occlusion, multiple blood vessels occluded that are supplying the brain, but simultaneously they can have coronary artery occlusions, they can have renal artery occlusions, they can have pulmonary embolism. All these things can occur all at the same time in the same individual. Okay, so suggesting that there's some kind of coagulopathy that's probably going on. So those are infarcts, but then there are other individuals who can get microhemorrhages. So as it's shown in this middle scan here, you can see these bleeding points, and most of them are at the gray-white junction. But you can see a lot of microhemorrhages here. And then you can have other patients who get venous occlusions. So here you can see an occlusion of the sagittal sinus. But any of the venous system can get occluded within the brain. The other interesting thing is that if you look at all these various manifestations and see what is the onset of respiratory symptoms, cerebrovascular disease can occur before the onset of respiratory disease. So these patients, older patients, can present with a stroke. They don't have respiratory symptoms, but you still got to make sure they don't have coronavirus, because the management is going to be very different. So that is a key thing to remember. Okay, so what about thrombosis? So this is a group from University of Michigan. What they looked at was antiphospholipid antibodies. Okay, and what they found was that nearly 50% of the patients had some positive antiphospholipid antibody. When they looked at high titers, they found that about 30% of them had pretty high titers of antiphospholipid antibodies. Now, the problem with antiphospholipid antibodies is that they can go up with any kind of infection. So it's called an acute phase reactant. The question then is it of pathogenic significance or not? So what they did was they took these antibodies from these patients, take the serum, and put it in mice. And what they found was that these mice were developing thrombotic events, showing that these antibodies really have pathogenic significance. We looked at some autopsy cases, and this is cases we got from the New York Medical Examiner's Office. And you can see these congestion of blood vessels, a little microhemorrhage here in the cerebellum, and other small bleeding points here. This is another group, and they looked to see if there were factors that can predict who is going to develop these kinds of bleeding points and or hemorrhages. And what they found was that those individuals who are ApoE positive, ApoE4 positive, and they are more likely to develop hemorrhages in all parts of the brain over here. And the total number of hemorrhages is also higher in that population. Right? So both things, more regions of the brain and more a number of hemorrhages also. Okay, what we did was we did MRI scans of autopsy tissues, and we put them here through a 7 Tesla scanner. Okay, and it's very hard for us to get access to these high resolution scanners at NIH because all kinds of other research studies been doing. But during COVID, the entire institution was shut down, and about the only thing you could do was do COVID research. So they were only happy to put these brains through the MRI scanner. So we scanned them for the entire weekend, and taking 100 micron sections throughout the brain. When we did that, we noticed that there was a lot of vascular pathology. So this is the medulla of the brainstem, and we focused on this blood vessel here. When you blow it up, you see that there are several pathologies. Number one is you see the blood vessel wall is thickened. It has a high intensity signal there. In the middle of the blood vessel is a small blood clot. And the same blood vessel cut in a different plane, you can see there's a microhemorrhage here too. So you have 3 different pathologies in the same blood vessel. So this is extremely unusual. And so the management of these patients becomes extremely complicated. So this is an interesting study that was just published. And what they looked to see was that does inflammation contribute to strokes? Okay. So they looked at 2 things. One is they looked at the D-dimer levels, and they found that the D-dimer levels are greater than 1,000. You can see that the chances of stroke are much greater. Your mortality rates from stroke, outcome from strokes is much greater. Okay. The second factor they looked at is the neutrophil lymphocyte ratio. So if the neutrophil lymphocyte ratio is higher, that also predicts poor outcome. Yeah. So I think it's important to look at these things because it suggests that acute inflammatory state may actually predispose to stroke formation. Another interesting symptom that some patients will develop is this ringing in the ear. It's called tinnitus. This is usually accompanied with decreased hearing also. And my feeling is that this is most likely due to occlusion of the blood vessel to the cochlea, to the inner ear. And so it should be treated like you would treat a stroke. And there are patients who will develop vestibular disorder. So it's the same thing, If you get a vestibular disorder, tinnitus, these things are occurring at the same time. They are likely due to occlusion of blood vessels. And sometimes these may be the presenting symptoms, so they don't have other symptoms. Okay, what about the subacute phase? So there are a number of different types of inflammatory syndromes that can occur in this patient population. And so one is acute disseminated encephalomyelitis. Okay. And so this is just like any other disseminated encephalomyelitis. You can see a ring enhancing lesion over here, some punctate regions of enhancement, and you can see enhancement here in the spinal cord. Okay. So we think that this is largely T-cell mediated. And I think that's important because the treatment will be targeted against that kind of inflammatory process, right? Some patients may develop these kind of lesions in the thalamus. And it's called acute necrotizing hemorrhagic encephalopathy. Necrotizing because you can see blood here in the thalamus. But it's bilaterally symmetrical. And that suggests to you that there's probably something more systemic. And what we think is that this is cytokine mediated. Okay. Now it can start in the thalamus and can spread to other parts of the brain. And so the treatment would be targeted against the cytokines, right? So IL-1, IL-6, those are the ones you want to target in this patient population. Okay, then there are children who develop this syndrome called multisystem inflammatory syndrome, or MIS-C. It can occur in adults, at which time it's called MIS-A. And these patients can have some systemic symptoms, and then a couple of weeks later, so there's a little hiatus of some time before these symptoms develop. So they're covered from the acute phase, a little period of time, and then these symptoms develop. They can become encephalopathic, and you can have dysarthria, dysphagia, generalized weakness. If you look at the brain, you'll find that there's a hyper intense lesion in the splenium of the corpus callosum. Usually the CSF is normal in these patients. However, you will find markers of inflammation systemically. And they will respond to treatment with IV corticosteroids, but it has to be given early in the course of the clinical manifestations. The other interesting thing is that a number of the peripheral nerves and cranial nerves can get involved as well. So some patients can develop a Miller-Fisher-like syndrome. Right? Others can present with ophthalmoparesis and cranial nerve palsy. And here you can see this patient here has enhancement here of the third nerve, and also the second nerve here, as you can see. And this patient here has enhancement of the L5 root. So they can also develop polyradiculitis. It's not clear what is causing this enhancement. There's one group thinks that there's actually virus there, and that's what is happening. But others think it's just an immune-mediated phenomenon. But nonetheless, the interesting thing is that all these patients responded to treatment with IVIG. So that's the important thing to remember, is to recognize these neurological symptoms early enough, give them immunotherapy. So all these syndromes that I've showed you so far will respond to either IV corticosteroids or IVIG. Okay. Then the peripheral nerves can get involved. You can get a peripheral neuropathy. Usually it's an axonal neuropathy. Small fibers are involved. And patients will complain of tingling, pain-like sensation. Sometimes they develop autonomic symptoms as well from the peripheral neuropathy. But then the muscle can get involved too. And you can get this myositis. You can see inflammatory infiltrates here in the muscle, some necrotic muscle fibers. And at the bottom here is HLA antigen activation, suggesting this is an immune-mediated phenomenon. And again, you can treat them with IV corticosteroids. Okay, what about long COVID? So the definition of long COVID is a problem, okay? So WHO has a working definition for long COVID, but it's very encompassing. And that's a problem because what we know is that if you're hospitalized and you come out of the hospital, out of the ICU, you're never going to be completely normal. It's going to take a while for you to get normal. Sometimes you may not get completely normal because you have damage to other organ systems, right? But it doesn't suggest that there's something active going on long-term. It suggests that acutely you are so ill that you have lingering symptoms. So you have that one subset of individuals. It's also true that new symptoms can arise even if you have mild symptoms initially. And so this is an interesting study that comes out of the United Kingdom. And because they have a National Health Service, they have very large sample sizes that they can tap into. So this is about 80,000 people, and they looked at them at 4 weeks and 12 weeks, divided them by the fact that whether they have 1 or more symptoms, 2 or more, or 5 or more symptoms. So if they have 5 or more symptoms, right, then they at about, there are lesser number of individuals, but by about 3 months or so, they still have symptoms that persist, right? And even if you have only 1 symptom, you may not get completely better. Some people get better, but if you don't get better by about 3 months or so, your symptoms will persist. And the other thing they found was this is more so in women than in men. And so they interpreted that to mean that maybe that suggests there's an immune-mediated phenomenon. Okay. Now, there's another study that came out of the Netherlands. Here, what they did was they again looked at the participants here And so they divided them into mild, moderate, and severe at the time of onset. And so now here you can see that if you had severe illness, and if you didn't get better by 5 months, so people keep getting better. By 5 months, if you don't get better, symptoms persist for each of these categories: severe, mild, moderate. And this interesting data, because they think that 50% of patients with moderate to severe illness and 20% with mild illness have residual symptoms at 1 year. So I told you what I like to do is actually divide the so-called long COVID into two sets of individuals. Okay, one is the ones that are post-intensive care syndrome. These are individuals who are really sick, came out there. Then there are these others that are individuals who have symptoms that developed after recovery from the acute phase itself. And these individuals have a variety of symptoms. I divided them into 4 different buckets. But really, the top 2 can probably be collapsed a little bit closer, and the bottom 2 can be collapsed a little bit closer. The top 2 are indicating CNS involvement. Okay, so they have exercise intolerance or fatigue. They don't like to call it fatigue, but they like to call it more exertional dyspnea. And so, which is kind of interesting, because I talked to one cardiologist, and what she said was she took a flight of steps. And after that, she got so exhausted, she couldn't even do telemedicine any longer, right? So it's not really true fatigue. It's because she was a cardiologist, she had her heart and lungs and everything checked out, and there was nothing wrong. And the other patients who complain of brain fog, what they mean is they can't really concentrate very well. And they make a lot of mistakes. They miss their exit on the freeway. There was one congressional aide I met. This person's job was to take minutes for all the congressional hearings, and didn't realize that there was something wrong with her till she went back to her job, and now she couldn't really do what she was supposed to do. And then there's a lot of depression and anxiety. For the first time, you can get psychiatric symptoms that you never had before. So there's one construction worker here in his 50s at my institution here at NIH. This guy was perfectly normal otherwise, never had any symptoms, or any reason to be depressed, developed COVID, and after that he says, "Doc, I got scared of myself." He thought he was going to kill himself. He went and got himself admitted in the hospital. He was on the psych unit for over a month. And so he came out, he's doing fine now. But you can get first-time depression or anxiety that you've never had before from COVID. And then there are individuals who develop these pain syndromes and dysautonomia. And this is actually a major problem. So there was one neurologist I talked to. She was an epileptologist here in this area. And she developed COVID, and the dysautonomia was so bad. She says that when she was talking to me on the phone, she couldn't even sit up in her bed to talk to me. Right? She had to lie down in order to talk. So it can be really bad. Now that patient we treated with IVIG, with several courses of it. She finally recovered completely. Now she's back to her practice. But she was quitting her practice because she couldn't really do anything. Okay, so just as I said, you divide them into 2 groups. One is very severe at onset. They don't get completely better. But this is the group whereby they have mild symptoms, they get better, there's a hiatus of some days to weeks, and then they develop new symptoms of long COVID. Okay, so forget about the one on the left. Let's look at the one on the right. So these are patients we brought to NIH, and we looked for all kinds of symptoms. 100% of the patients that we brought here had cognitive symptoms and this exercise intolerance called fatigue. And then they have other types of symptoms, but that's variable. But the other important aspect of this is if you look at the left-hand side, these gray bars here, this is the number of weeks after the start of COVID that they develop all these long COVID symptoms. So it can be as much as like a month to 2 months sometimes usually up to a month, before these patients may actually develop all these other symptoms, new symptoms. So one's got to make sure that you don't miss that history of COVID just because they're coming with new symptoms that you're not sure what they're due. Right? So in fact, now when you see a patient in the clinic, it doesn't matter what they have, you got to take a COVID history on them and a vaccine history on them, because you have no idea how that may be impacting their disease. That just has to become part of your routine for every patient you see. This is an interesting study, just came out. And so besides all the symptoms that I showed you there, they claim that they are individuals who develop restless leg syndrome. This is an interesting study because they had participants from before COVID and after COVID. And they found that after COVID, they have about 15% of their population was developing these symptoms of restless leg syndrome. And the severity is also higher compared to controls, right? Now, restless leg syndrome is an interesting disease, something that has something to do with iron metabolism. So it's quite possible maybe something goes wrong with the iron metabolism when they're ill, but I don't know for sure. Unless we treat them, we wouldn't really know. Now, what is really happening with the brain? I told you that they get this brain fog and all kinds of other neurological symptoms, but how do you know that this is not just all, is it a more generalized phenomenon affecting the brain, or is it focal and localized? You can find evidence for both. So this is a PET scan study, and what they did was, this is a consensus PET scan of healthy individuals, and this is of patients with neuro-COVID. And you can see that the glucose uptake in the cortex is decreased compared to the controls, suggesting that there's some global phenomenon affecting the brain. And this is another one here. They look for regions of hypometabolism. And what they show is there are focal areas, but largely in the hind parts of the brain. Okay. And so they make the case that maybe this is involving the olfactory pathways, which is an interesting idea. But the olfactory pathways can end up in the brainstem. Basically two neurons in a single synapse that is necessary to get here. This is another interesting study, again, comes out of the United Kingdom. And they were at an interesting database where they were annually doing MRI scans on a normal set of individuals. There are thousands of individuals, and they were getting MRI scans on them periodically, trying to see what the natural history of aging is. So some of them developed COVID. So now they had cases that had MRI scans before and after COVID, and those that did not develop COVID. So they compared them, they stratified them by age, about 400 in each group. And what they found was that the volume, total intracranial volume, as well as the hippocampal volume here, was decreased in individuals with COVID and in an age-dependent manner. So the older you are, the more severely you're affected. That is very concerning because now that brings up the issue, is it possible that if you follow these patients long enough, they would develop other kinds of neurodegenerative diseases, right, at an earlier age? And they also showed that with neurocognitive batteries, these individuals who had developed COVID also did much poorly on the neurocognitive battery. So it's not just atrophy of the brain, but the functional outcome is also impaired. So what you want to know is the virus in the brain? A lot of reasons to think that the virus should go in the brain. First of all, just look at the location of where the virus is. The virus is here in the mucosa, nasal mucosa. And there's lots of virus coming out of the nasal mucosa. It infects the nasal mucosa. And the cribriform plate is right here, and the brain is right above. So you would say that if you have that much virus here, it shouldn't take much to think about that the virus can probably just go through the cribriform plate and get into the brain. But it's not that simple. Okay. What the virus does not do is it does not infect the olfactory nerve. Okay, so the olfactory nerve is not infected. What it does infect is the sustentacular cells, and these are the support cells over here. Okay. So because it doesn't infect the nerve, it doesn't have an easy path to get into the brain. Now, the loss of smell is because you get infection of these other cells, you get inflammation, and they can compromise the function of the olfactory nerve itself. So if you look under electron microscopy at the nasal mucosa, what you find is there's huge amounts of virus. All these round little dots are viral particles. Okay. So there's copious amounts of virus coming out of the nose. However, if you did PCR looking for the virus, so this is a group in Germany, and they looked at it, and what they found is that, yes, in the olfactory mucosa, there's lots of it. This is an autopsy. If you look at the olfactory bulb and the olfactory tubercle, you hardly find it. So 3 patients here and 1 here, very low levels, okay? Because this is a log scale. So extremely low levels is all you find in very, very few individuals. So there are reports of finding virus. When people do find it, they find it in very, very low quantities. We have not been able to find any. We've looked at it from many different types of ways. And maybe we are a little bit conservative in calling it, because if it's kind of borderline detection, we just err on calling it undetected. While others may actually say maybe it's detectable. But certainly, even if you believe that there is some virus, it cannot explain the pathology that you see. The pathology is very profound. This is another group at NIH that claimed they found virus everywhere in the body, wherever they looked. But again, if you dig deep into it, you find there's hardly anything there. All of it is sitting in the respiratory tract. Okay, so they looked at various kinds of brain tissues here, but the amount they found was very, very small amounts. Okay, so here's the central nervous system. You can see. Less than 14 days, they find a little bit, and then it's more than 14 to 21 days. So it's most likely a lot of that is contaminant. It's all ground up tissue. They claim that in some patients who are greater than 31 days post-infection, they found very small amounts of virus. So I think that is kind of interesting. If that really holds up, maybe in some individuals, the long COVID may be explained by viral persistence. I don't really know. I think we need to keep an open mind. Okay, so we looked at the pons here. Again, this is an 11 Tesla scanner. And what we found was that there were all these areas of vascular congestion or microhemorrhages. So what we did, wherever we saw it, we then went back and made sections from the pons and then stained it for various kinds of things. So here we stained it for fibrinogen. Okay. So fibrinogen is a large protein. It's usually present in the blood vessels. It should never get into the parenchyma. But all this brown stuff is fibrinogen in the parenchyma. And in fact, you can see around the blood vessels, it's very dark. The further out you go, the less dark it is. So that suggests to you it's coming from the blood vessels into the parenchyma. So the blood vessels have to be compromised. That's the only way this will happen. Okay. And same thing here in the olfactory bulb. You can see a lot of fibrinogen here sitting in the olfactory bulb. So then we looked further into the blood vessels, and what we found was that we found a lot of platelets here. Okay. And these platelets were immunostaining for this antigen CD61, which stains activated platelets. Now, if you look at the activated platelets, most of them are sitting right next to the endothelial cells. So you can see here on this third one here, the endothelial cells and the very small branches here, they're almost occluded completely. So the question is, what's really happening? Is the platelets activated first and then sticking to the endothelial cells? Or are the endothelial cells getting activated and then the platelets are sitting there on top of them, getting activated secondarily? So hard to tell in a autopsy brain tissue, but I'm going to present a hypothesis to you. Okay. The other interesting thing is we find more of it in the posterior parts of the brain. Okay. So what we did was we immunostained for a number of other antigens. This is all in paraffin-embedded tissues. So one is this adhesion molecule that's present on endothelial cells. And this is a control on top, and this is a patient with COVID. And you can see there's just massive expression of PCAM1 on the endothelial cells, right? Then there's also deposition of complement. So on the same blood vessel here, you can see complement 1Q, 4D, and 5B. So these are the only antibodies that work in paraffin tissues. But what I suggest to you is that the classical cascade of complement activation is activated. Okay. Now, what is activating that thing? We look for IgG and IgM. We found some IgG, but look at the IgM that's there. Lots of IgM. And you don't find any of that in the control tissues. So this is an antibody-mediated phenomenon that's leading to activation of the endothelial cells. And I think that's the primary phenomenon that's taking place. And the platelets are sticking to it after that. And this activation of the endothelial cells is probably what is causing the compromise of the blood-brain barrier and leakiness of all the proteins. So we believe that this is the primary pathology that's taking place in these brains. And so we looked at the inflammatory infiltrates. Okay, so we looked from macrophages, we looked at activation of astrocytes. You can see here a lot of macrophages, all in the perivascular region. Now, when we look for T cells, we didn't find any. Very few T cells. Okay, so I'm showing you the best pictures. So here are some CD3 cells, CD8 cells. Not very many T cells. If this was a viral encephalitis, you would find T cells, find lots of T cells, and no T cells. The macrophages are predominantly in the perivascular region. So that suggests to me they're coming here to clean up the mess. I showed you if all the fibrinogen, all those things are coming into the parenchyma here. And so it's quite likely these macrophages are coming in to clean up the mess. But once they get in, they don't leave. That's the problem. They're the unwelcome guests, you know, and they stay activated. So they can cause a lot of harm. Now, there are other studies to support this phenomenon. So this is a study from Germany, and they looked at the spinal fluid of patients with neuro-COVID. They found dedifferentiated monocytes in the CSF. Those are extremely activated monocytes. They found that the interferon responses were decreased, and they found that the T cells were exhausted in the CSF. Exhaustion markers were activated. So that's a bad combination, because it suggests to you that your adaptive immune responses are impaired, and what you have is these activated macrophages that are now taking its place, and those are bad actors because they're not directed against the pathogen. They just produce all kinds of oxidative stress and cytokine production. And it's like blanket bombing, you know, they just don't know where the enemy is, just kill off everything on the way. And so once they're in the brain, it's bad news. So as I told you that, and maybe I did not. So a number of these brains that we got were individuals who had died suddenly, okay? So they were found dead in the subway in New York, or they were found dead at home. And one person was just playing with his sister and he just fell down dead. It wasn't entirely clear, and they were not sick enough to go to the hospital or to see any physician, and there was hardly anything in their lungs, very little inflammation in their lungs. So one of the things I was concerned about is I said, I want to look at their respiratory status in the brainstem. And what I was interested in is this pre-Bodzinger complex, okay, because that's the respiratory center. But I don't know how to look for it. So what we did was we did this high resolution MRI scan, 11 Tesla scanner. You can see the beautiful anatomy of the brainstem, right? Then I pulled out an atlas and mapped each of these nuclei. Then looked at it under the microscope, and what you can see is that there are atrophic neurons here. And you have these microglial cells that are activated around the neurons. And on this H&E stain here, you can clearly see that there's neuronophagia taking place here. So these activated macrophages are killing the neurons. So one possibility is that these patients lost their respiratory drive and they're dying because of Ondine's curse. Okay. Other long-term consequences, as you can see here, their neurofilament levels are elevated in patients in their blood and CSF. and the amyloid beta peptide levels are down. So that suggests to you that they may be at risk of developing Alzheimer's-like pathology. And certainly there is neuronal damage that is occurring in these patients. Another study here, these are from hospitalized patients. And again, there you can see NFL levels are very high. GFAP levels are also high. So this is an interesting study. Here they looked at NFL levels in the CSF and then followed these patients for 18 months. 18 months later, they put them on this Rankin scale. The higher the scale, that means the worse the outcome. And you can see that there's some correlation between the neurofilament levels and 18 months later what their functional status is. And that's statistically significant, suggesting that neurofilament levels at the time of onset can predict your ultimate outcome. Now I'm going to skip this slide. So now the question is that, what about other types of pathologies in the brain? So this is an interesting study in macaques. And what they did was they infected them with SARS-CoV-2. And then they looked at the brain and they find that there's synuclein aggregation in these neurons here, okay, suggesting that Lewy body formation may also be increased. So not just amyloid, but Lewy body aggregation. So protein aggregation may increase in the setting of SARS-CoV-2. That for us as neurologists is of great concern because we need to follow these patients. It's quite possible over a period of time, you might see them developing all kinds of neurodegenerative diseases at an early stage. Right? They also looked at phosphorylated tau. This is another study here. And they found that they looked at old and young individuals and then cortex and cerebellum. It doesn't really matter whether you're old or young, and it doesn't really matter what part of the brain you look at. There is increased phosphorylated tau within the brain. Okay, more so in the cortex than the cerebellum. So this is our hypothesis here as to what is happening. And so they are, as I said, an immune attack to these blood vessels. There's perforation here. Macrophages come in. They release all kinds of cytokines, antibodies over here. The platelets aggregate, form these little clots. You can get microhemorrhages. And then ultimately, these microglia get activated, and they can cause neuropathogenesis. Okay. So one way to study these things is with animal models. Unfortunately, we don't have good animal models. They cause very mild disease. So, and there are some that people are doing with ferrets and mink. The problem with these animal models is that we don't have the tools to study them. And so how should we follow our patients? So I think the way to follow these patients is we need to use a panel of biomarkers. Ones that look for neural injury, for vascular injury, and immune activation. Okay. So you need all three of them to follow these individuals, the long COVID patients that you're going to follow. And currently, a lot of these things are available through research labs only, but I think the push should be to make them commercially available. Okay, standardize these things and make them available. And if you're going to do clinical trials, I would suggest considering immunomodulatory agents. And depending on the clinical presentation, you can think of various types of, various arms of the immune system that can be targeted. Okay, so I'd like to conclude by saying that direct invasion of the brain by SARS-CoV-2 is rare and does not explain the neurological complications. Neuroimmune dysfunction is driven by activation of innate immunity, immune exhaustion, and antibody-mediated phenomena. Endothelial cell damage by immune complexes is the primary pathophysiological process in neuroCOVID, and neuroinflammation may accelerate protein aggregation. A number of people I'd like to be able to acknowledge here. Marco Hefti and Rebecca Folkert provided us the autopsy brain tissues here. Daniel Pearl, Eliezer Maslia, and Serena Spudik. Daniel Pearl and Eliezer helped us with interpreting the neuropathology here. And Serena and I wrote a review on the topic. And I also want to thank Carlos because we learned a lot of tricks about how to do good immunohistochemistry from him. So we've been applying it over the years over here. And then this is our team who did the immunostaining, our clinical team over here, and the MRI team, and Walter was the director of our institute. So I'll stop here and take questions.
Thank you, Avi, very much for this beautiful lecture and update about COVID-19. And muchas gracias, Dr. Nath, por la actualización acerca de COVID-19 y los problemas neurológicos. Le voy a dar el micrófono a la doctora María Isabel Reyes y Paula Barreras, que van a coordinar la sesión de preguntas y respuestas. María.
Muchas gracias a todos, and thank you, Dr. Nath, again. So I'm going to be reading the questions in English, even though the first question was written in English itself. So this is from Dr. Felipe Ocampo. He's a physician, and he's also an ALS patient. And he says that he got the 3 shots of COVID vaccine. He got Moderna vaccine. And after that, more recent, he had a mild COVID infection. During the mild infection, his spasticity and his speaking and his swallowing improved. So he's wondering if you have seen any similar reported activity, kind of like improvement of his previous symptomatology, ALS related, while having the mild COVID.
Yeah, that's a very interesting observation. I certainly haven't heard of that. Now, there are patients who had chronic fatigue syndrome who claimed that when they developed COVID or when they got the vaccine, they actually got better for a little while, and then their disease continued to progress. So at least temporary improvement has been reported by these other sets of patients. The reason why that happens, I'm not entirely clear, but maybe some inflammatory mediated process is helpful in that. Is my guess, but that's very interesting.
Thank you. I'll read the next question. So this is from Enrique Urrea. It says, thank you so much for your excellent lecture. What is your opinion about the relationship between COVID and movement disorders in the acute phase? There are some cases of opsoclenus-myoclenus syndrome published, reversal Parkinsonism, and Guillain-Barré.
Yes, so you're right. All these syndromes have been reported. The thing is, just by chance alone, some are going to occur, no matter what, right? So the only way to know whether they really are part of the pathophysiology of the disease is to really have a large cohort that you can really do good epidemiology on. Otherwise, almost every disease known to man has been reported with COVID, from Jakob Creutzfeldt's to, to cancer to what have you. And so it's quite possible some of these things are related, but we really need to do good epidemiology.
I guess I'll jump on that with a question of my own before continuing, which is sort of similar. How do you reconcile all of these reports of very different disorders that would have different physiopathology mechanisms, as linked to COVID, when we haven't been able to demonstrate the virus, mechanistically to cause them?
Yeah.
Do you think there are coincidences, or is there a subset that you believe is more likely related than others?
I mean, some of it has to be coincidence, right? We have such a large population infected, hundreds of millions of people. So they're destined to develop some other diseases at the same time. So by chance alone, you're going to get some kind. Now, the problem is that maybe some of them are truly related. Not all of them can be. If there's no virus to be found, it has to be inflammation. Or you can trigger some underlying disease just by the process of having an infection. So that can also unmask underlying diseases. That's another possibility. That would be my.
We'll read the next question. So this is from Gonzalo Arboleda, who says, thanks for the talk about the role of ApoE4. Can you expand about the potential relationship of ApoE4 with COVID and blood-brain barrier damage and inflammation? Thank you.
Yeah, so ApoE4 is very interesting. I can't say I understand everything about it, but it's been associated with Alzheimer's, right? And if you are homozygous for ApoE4, then the incidence of Alzheimer's is extremely high in that population. And it has to do with it's a lipid carrier molecule. And so how it affects the vasculature is very important there. And we think that that is probably an important aspect of the pathophysiology of that disease. And here I showed you that there's vascular pathology here as well in these patients. So it's quite possible that may be a common link between them. although there are several other mechanisms that have been postulated with it in the context of Alzheimer's.
The next question is from Professor Leo Osorio. She's saying, thanks for the presentation. What mutations in the virus would favor neurological tropism in future variants?
So the thing is, if you were to take brain tissue and culture, like organoids or something, and put virus on there, they'll get infected. So there is ACE2 receptor present on brain cells, and you can infect them in vitro. The question really is not the infectability of the neurotropism. The question really is that the virus probably never gets to the brain. And in fact, you can't even demonstrate viremia in patients who are acutely infected. You can't demonstrate virus in the CSF who are acutely infected. So it's trapped in the lungs, and the immune system gets hyperactivated there. It probably controls it to some degree, and the inflammation persists. If you were to be immune suppressed, for example, and you don't have the ability to control the virus, then my guess is it'll get to the brain and it'll infect.
Question, Dr. Nath, is from Dr. David Acero is, are there any differences between the neurological manifestations of primary infection versus reinfection? Any kind of immune enhancement leading to worse symptoms?
So I haven't seen that many patients with reinfection, but intuitively what I would say is that if you recovered once from it, there should be some immune tolerance to the virus. So a reinfection can, you should be able to control the virus better. And if you can control the virus better, maybe the symptoms will not be as severe as previously. That doesn't mean that it cannot occur. You can still get symptoms from it, but they shouldn't be as severe as you get for the very first time. The opposite can be true if what is causing your symptoms is really an autoimmune phenomenon of sort, right? Then what happens is the second trigger can actually cause even a more severe autoinflammatory syndrome, and your symptoms may actually get even worse with the second infection. So you can postulate both scenarios depending on the type of pathophysiology underlying.
And Dr. Nath, before I read the next question, I guess that in those lines, what would you suggest? Because I think that through the pandemic, we saw some of these cases, like not especially, but some of these cases associated to vaccination with some optic neuritis and some traumatic myelitis associated to some of these vaccines. So it's very often kind of like what to do if you counsel the patient about like getting the booster, but if you're thinking that this was related to the virus itself, so, I mean, if they get the infection, so how are you advising these patients in those special situations?
So currently the advice has been to not give the second dose if you develop a neurological complication from the first dose. Having said that, I have one neurologist that I know of. This person developed a anaphylaxis from the first shot, wasn't a neurological complication. And then said that they were so scared that because they lived in an area that the incidence was so high over there, that this neurologist said that they wanted to get the second shot, even though there was an anaphylaxis from the first one. So I said, okay, if you really want to get it, it has to be done under very close supervision. And so we consulted an infectious disease specialist, an immunologist, a rheumatologist, and myself. And we said, okay, you get the shot. We will monitor you. If you develop any symptoms, we treat you immediately. So in the hospital setting, gave the second shot. Okay. This person then did not develop anaphylaxis the second. She had taken some antihistamines and other things to pre-medicate herself. And so there were no anaphylactic-like shots. But then I called the next day, and the neurologist told me that she was kind of foggy and she couldn't really think properly. And I said, this is crazy. I mean, you need to get some corticosteroids now. So she had a Medrol dose pack that she had taken through prescription earlier and took it immediately. By the next day, all her symptoms resolved completely. Okay. So she did manage to get the second shot. She did have neurological symptoms from the second shot, but she was treated with corticosteroids and she got better. So if somebody really needs to get the shot, I think it can be done, but it has to be done under close supervision. And don't be afraid to give corticosteroids. If a person has side effects from the vaccine, give them a shot of corticosteroids. You can reverse it if you give it early on.
Thank you so much again for the presentation. I would basically ask one final question. And
yeah, I'm available. That's not a problem.
Lida Osorio is one of our epidemiologists in NEAS. Is what neurological syndromes would you recommend for early warning surveillance system of potential changes in the clinical presentation of COVID-19? And actually, that is very relevant for all of us who are working in neuroepidemiology and the relationship of infections and neurological disorders.
So if you're looking at acute infections, the most common symptom is anosmia, right? So is loss of smell. So in fact, at the time when the PCR test was not available and then it got botched up at the CDC, your diagnostic accuracy of COVID was better by a smell test than it was by a PCR test. It was better than PCR. Yeah. So that is certainly in the acute phase. In the chronic phase, where you're looking at if you're looking at long COVID, then your best bet is really this so-called brain fog and autonomic dysfunction. Right? So they are very prominent symptoms. And you can be quite sure when you talk to these patients, they are brand new symptoms. They're not functional. They really are real symptoms. And the autonomic dysfunction is also pretty dramatic in these patients. So I'd certainly go for these for you. And certainly at the whole battery that I showed you, you should probably look for all of them. But if you're going to cherry pick a few of them, I'd certainly put these 3-4 things on the top of your list.
Do you foresee any biomarker for diagnosis?
Well, it looks like this neurofilament is actually not a bad biomarker. Yeah. So its levels shouldn't go up unless there's some kind of neuronal injury. And there are now a lot of studies in the literature all confirming increase in neurofilament levels during the acute phase of the illness, and maybe the subacute phase of the illness. Yeah. Great.
Well, thank you, Avi. Thank you so much for being present in this inaugural session, Grand Round of NEAS.